Because there's something which you learn and you find out, like the Sherlock Holmes, about things which others can't see. So you may have hundreds of very good retina surgeons, but you will see in the patient what they cannot see. And what I'm going to talk about flashy as the interpretation and variation. So the patient comes to you with a report, and now you want to know, like, what does it mean? So it's not just if you're a retina specialist, you may be any specialist. Nowadays patients come to you with the reports, OCT, ERG, and it will look very funny if you can't even, look at that report and say, like, I don't know what this is. So I think this session is going to be very interesting. So I'm going to say that, first of all, there are few waveforms which we should know. So the first thing to look at an ERG is to see whether the waveforms are good or not. So they can be all noise. Patient may blink his eyes and there may not be any good response, and the computer will put up some ABCD on the computer and it will give you some data. But what we want to check is there first a good waveform. So these are what we said, noiseless waveforms, very clear cut. The rod response is bell-shaped curve, tall, the maximal combined response, a downgoing sharp wave and an upgoing long wave. And then the oscillatory potential, so 4 or 5 very clear-cut waveforms. And then you can have, in different machines it may look different. So this is with the LKC machine and this is with the metro machine. So depending on the type of machine, type of electrode, they may look different, but you should know what is the normal of your machine. So even if it's a different machine like this, Metrovision, this is how the same waveforms on that machine look like. So these are all normal data, they are not abnormal. Okay, then there's something called intensity response curve. So sometimes we want to know about the rod function. Normally what we see is that when we check the rod function, we get a B wave. We don't see the A wave. So normally rods and cones photoreceptors give the A wave. But when you do dim flash, you can't see that A wave because it is too small for the computer to pick up. So it's not that the wave is not there, it is there but we can't pick up. So if you get an absent B wave in your rod response, it doesn't mean that the photoreceptors are dead, because you can't see them, so you don't know whether they are dead or not. So in that situation, to check for rod function, you do what is called as intensity response curve. That is, slowly increase the intensity, and as you increase the intensity, what should happen to that scotopic A wave is it should slowly start appearing. You can see here. So with time, so these are the flash intensities. So this is the dimmest flash, that is 30 decibel. That means it's 30 decibels attenuated than normal. And as you are increasing the flash intensity, the A wave starts appearing. It starts becoming deeper and faster. So this is what should happen, and the B wave also starts becoming taller and faster. So you can see the bell-shaped curve finally changes into a peak curve. So if this B wave intensity is going along this path, that it is slowly increasing, the V max, that is the B maximum amplitude is increasing as we increase the amplitude, and then it forms a plateau. So this is what is called as Naka-Rushton equation or a sigmoid curve. It forms a sigmoid curve. This is what should happen in a normal eye which has healthy rod photoreceptors. If the rod photoreceptors are dead, then you will not see this change. You will not see this B wave changing with change in intensity. So then you can say, okay, this absent B wave in my response is because of photoreceptor death. If the B wave absent is because of photoreceptor connected to the bipolar cell, because B wave tells you about the bipolar layer. So if this is not happening, or the B wave is still coming but you are not getting the A wave, then you know that, okay, this B wave is problem because of the inner retina. It's an inner retinal disease. So when you look at the scotopic response, don't automatically think that an absent low intensity scotopic response means that the photoreceptor is dead. It could be either because photoreceptor is dead or only the bipolar cell is dead. And that answer you can get from the intensity response curve. So in the clinic we don't do intensity response curve routinely because it takes a lot of time. But what you can do is do a dim flash and then do one of all these. So you can do a 30 decibel or a 25 decibel and then do 110 and then you do your maximal. So then you can interpolate the points in between. And in a given patient, if you find that B wave is absent, then you can go ahead and do a full intensity response curve. So this test is also a very good test to check whether the company who is selling you the machine, is he selling you a good machine. So this is the test we do. If somebody asks me, like, there's a new machine, is it robust, is it good? So for you to know that what it is recording is the truth and it is not some artifact, this is the test we do. And if it gives us that Naka-Rushton sigmoid curve where the V max, that is the maximum amplitude of the B wave, is going, the log of maximum amplitude of B wave is going along the intensity in a very regular fashion, then we know, yes, it's a true response and it's a very good machine. So this is about the scotopic, and these are the flash photopic waveforms. So in the light adapted eye, what we see is that the photopic single flash is a smaller flash response and it is steeper and faster. So this is on the LKC machine. and this is on the Metrovision machine. So as you can see, depending on the machine it may look different, but that's what you find. And what you find below is the flicker. So in the flicker, what we are doing is we are giving 30 bright flashes every second. So 30 flashes per second, and you can see that if you give this flash, it gives this response. If you give this flash, it is giving this response. So the response of the flash comes just before the next flash. So you can just look at this and you can know whether it's normal or not. So I'll be showing some places where just by looking at it you can know, okay, it is delayed because it is coming in between two flashes, or it is coming after the flash. So those straight lines are telling the flash. So same way in the other machine. So you need to see whether the waveforms are formed well, whether they are following a good pattern, or they are distorted. If they are distorted, then you know, okay, it's abnormal. One thing one must remember is that these flash ERGs are mass response. So they don't get affected little bit. If there is a pathology, they will get affected a lot. So it's not that, something was 200 microvolts and if there's a pathology, it will become 189. No, it will become 50. It will become 80. So there's a huge difference between normal and abnormal. And there's no difficulty in saying this is normal or abnormal or subnormal. It's not that they just change this, like 200 becomes 180 and now it's abnormal. That's the test-retest variation of this test. So the causes of variation that we should know can be physiological, technical and pathological, and we'll quickly go through some of these. So physiological, so there is a lot of difference by age, gender, refraction and all these factors. I'll go through one of them. So age and ERG, so newborns have an immature ERG, so there's no point in trying to do an ERG and comparing it to an adult ERG and say this child is going to be blind because ERG is coming flat. So we should know what is the normative for an age and then only compare it to an age match control. So a lot of us don't have that data of newborns or 2-month-old or 4-month-old baby, and so don't compare it to an adult and say, I have seen patients being brought to me and parents crying because somebody did an ERG, it came flat and they were told child is blind, and actually child is not blind. Okay, so we should see, and within a year of life it improves. So I don't do ERG in those very small babies. I go by the clinical picture or the finding. I put them through early intervention program, and if I have the data for that age, normative data, then I might do it. And so if you get a good waveform, it is good, but if you don't get a good waveform, it doesn't mean the patient is blind. They could still mature their ERG over a period of time. So that we should remember. Same thing holds true for the VP also in infants. So in adults with age, so once you reach your 10 years, 12 years, after that it will remain stable, and after 30, 40 years of life, it starts decreasing. So there's about 30% variation with age. So it's given here, if somebody has 400 microvolt at 10 years, it may reduce to about 300 microvolt at 70 years. So again, we should not just label that it's low for our age. So we should have at least every 10-year, decade wise normative data, at least 10 patients, 5 females, 5 males for that decade, 5 males, 5 females for the next decade. So you can have some idea of how it changes with age. Then gender, yes, females are brighter, so they have, larger ERGs. Now they have larger ERGs because the globes are a little smaller. Always smaller globes have larger ERGs. So we should know about that. So in routine clinical practice, this doesn't make much difference, but if you are doing a clinical trial or you are studying pre and post, then it will make a difference whether you compare it to females or males. So that's why it's good to have normative data, 5 males, 5 females, or 10 males, 10 females. Then refractive error. So this is something very important. Everybody should know that myopes have higher, higher the myopia, lesser is the B wave. So myopia itself without RP or without CSNB or without a retinal dystrophy will cause a huge difference to the amplitude and the waveform and the implicit time. So I do get a lot of patients where somebody has done an ERG for myopic patient and then sent to me like, is he having retinal dystrophy? So the higher the myopia and more degenerative myopia, the ERG will get affected just because of the refractive error itself. There are not very many reports on hyperopics. Actually, there's only one good report. So there is a thing that your students can do a thesis on, like their project on that. What is the effect of higher degrees of hyperopia? So the more the hyperopia, the larger the amplitude is. So so if you have a patient with high hyperopia, let's say plus 12 or plus 14, and his ERG is coming bad, that means he has a retinal dystrophy. Because he should have a supernormal ERG. So we should know that refractive error can change the ERG quite a bit. Then test-retest variability. So if you test the same patient again in the evening or in the morning or at the same time, there is almost a 25 to 50% change because it depends on how the electrodes have been put. If the electrode has been put in the same place. So with contact lens electrode, it may be little less, but with fiber electrodes, because it's very unusual for you to put the electrode exactly at the same place where it was put 2 hours back, you can have a variability. So that is why ICEV requires that at least 2 reproducible waveforms should be there so that you are sure that yes, this is the response and it's not noise or test-retest variability. So anything beyond 25 to 30% you take as pathological, but within that range it can be within test-retest variability. Diurnal variation, many people don't know that both visual acuity and ERG have a diurnal variation and they can be a change. So again, this is not important for clinical work. It's not like IOP that you want to monitor, but if you are doing a clinical trial, let's say a stem cell transplant or something, then you would want to take this factor into account, that the diurnal time at which the test is done can influence up to 13 to 15% change in your ERG. Then the pupil size, this we all know that if the pupil is not well dilated, it will have an effect. If the media is not clear, it will have an effect. Remember, silicone oil has poor conductivity. Many times people send patients to us for ERG before silicone oil removal to find out if I remove the oil, will the vision improve? It is not a good test. Silicone oil will show absent responses even when the retina is normal, because it cannot conduct those electrical responses from the retina to the cornea. So be cautious. So same way, if there is vitreous hemorrhage, this I told in the morning also, you can have an absent ERG and still patient may see 6/6 because this flash ERG doesn't check the macular function. So patients of RP can have extinguished ERG and still have 6/6 function, visual acuity. So don't use ERG to predict what is going to be the visual outcome of this patient after my surgery. It will not tell you anything about that. So uveal pigmentation, again, this is something people don't realize, that depending on whether you are doing a South Indian patient or North Indian patient, an albino patient, there will be difference. There is not too much data of Asian Indians, but there is data that albinos have larger amplitudes, very large amplitudes, as compared to Caucasians, and the blacks have less amplitude. So we expect that the Asian Indians, that is Indian population, should have something in between the whites and the blacks, but there is no good data of comparative data of how it changes. So again, that's a good small project for some optometry or first year resident to do, like if you have a North Indian patient or white Indian patient, or the skin pigmentation, if you can calibrate and say how does your ERG change, because we have so many different races or pigmentation of the retina, so you can do the fundus photograph and say how deep the choroid is and what is the ERG level. So dark adaptation state, again this has a profound effect on your rod ERG. If the patient has undergone fundus photography or indirect ophthalmoscopy before your ERG, then it bleaches the retina and then it will take almost a couple of hours to recover. So you should avoid fundus examination or photography just before you do ERG. If you do, then you have to do more dark adaptation. Then medications, again this is something we should know, that all types of medications which influence the electrical environment, that is the ions in the retinal tissues, will affect. So any general anesthetics, digoxin, quinine, steroids, barbiturates, patient on dialysis, patient taking Diamox, all these things will influence the bicarbonate, the chloride, the potassium, sodium levels across the membranes, which is what we are picking up, the potential. So we should know. So if we are doing some tests, we should know what the patient is on medication so that we can account for that. So we should not just think because something is coming abnormal, it's in the retina. We should try to correlate the clinical findings. So these are the physiological causes. Then we have technical causes. The most important is the electrode. So if the electrode is not properly placed, you can get an abnormal. So I've had patients where the disease is in the right eye, but the pathology on the ERG is coming in the left eye, and people are like, oh, we need to do some more tests. I know the electrode is not contacted properly. And how you can know about that is if all the waveforms in all topic, everything is coming low amplitude, but waveform is good. It's not extinguished, but everything is coming low, then you know, okay, the contact is not good. The electrode is not properly fitting or there's some connection problem. The corneal electrodes give the highest amplitude, but they can also cause corneal abrasion and they need sterilization. What we use is disposable electrodes, but the technician should be good to place it very close to the limbus, not cross the cornea, not be floating in the tear meniscus, then you will not get good amplitude. So depending on how you place the electrodes, you can get. So here we are comparing the DTL electrode and our LVP Zari electrode. They are exactly the same. This was published and we got an award for this. So people who have difficulty in getting very expensive electrodes, they can contact us and we'll help them to make the Zari electrode, which is extremely inexpensive and you get very good waveform. But they are not as good as the Burial and the amplitude changes, but the implicit time is same. Then the type of machine I told, the type of stimulus which is there, whether it's a stroboscope or it's a cathode ray tube, so different machines will give different types of outputs. Then there can be pathological causes. So if the disease is mild, it may give another type of ERG. If it is severe, it will cause another type of ERG. Sidrosis is a good example. And also this is showing something which everybody should know. So this is not a waveform. This is blink artifact. So how do we know it is blink artifact? One, it is not reproducible. You can see we have done this test once. We have done the test twice. But here this wave is not coming. Here it is coming, so this is not reproducible, so there is an artifact. The second thing is that there is no response which comes so late. All the ERG responses come here very early. So this is the stimulus, so they will come here. You can see where the responses come. There is no response which will come after like 200 milliseconds or 500 milliseconds. So that's how you can guess that this is an artifact, this is a blink artifact. So we put this sometimes to confuse, like what is the B wave. So they will measure and tell, okay, this is the B wave. But this is not the B wave. This actually patient has an extinguished waveform. This is a blink artifact, and this is common in patients with poor vision. So this is, we had an opportunity to record acute quinine toxicity. A student, actually a medical student, she took a lot of quinine to suicide, and she came with no PL. And when we did the ERG in the first week, it was coming extinguished, and after 2 weeks, we could see some waveforms, and we could see that on 10-2 she had, less than 10-degree field. This was the funder. So the quinine affects the inner blood supply. But then after 6 weeks, it developed into a negative ERG. So, if we had seen her here, we might have thought she has CSMB. So the things can change in certain situations. So we should be aware that variation can occur depending on duration, dose, at what point of time in the disease we are seeing. Same thing can happen in CRVO, before Avastin, after Avastin. So things can change. So we should be aware that things can change. So whenever you have a flash ERG reports, there are only few types of reports that you can make out from them. It's not a huge difficult thing to do. Once you put your mind to it, you can learn very quickly. So it could be a rod cone ERG where the rods are affected more than the cones. So I have asked this question in ICF many times, like, what do you mean more? Like, the rod is more than cone. What do you mean by more? So they are very vague. It's like they say it's an impression. So it's not that, okay, this is reduced 30% or that is reduced 50%. So they don't have a cutoff. But it's just like a relative thing which you sort of guess. But it's not something which you can measure and say, okay, this is more and this is less. So, okay, if rods are affected more than cones, or if cones are affected more than rods, then you say it's a cone rod ERG. And then it can be extinguished, that is both are affected. Or it can be a negative ERG where B wave is gone, A wave is present. Or it could be like rod is abnormal but cones are very good, or cone is abnormal and rods are good, and they could be sometimes very rare. But these are the common patterns that you can easily decipher. And this was shown in the morning, again we show. So if you have a patient with unexplained vision loss, you should not say like do flash ERG to tell us what is the visual acuity of the patient. I already told that flash ERG will not tell you anything about the visual acuity of that patient. To explain visual acuity, we have to do macular function tests, and then to know whether only the macula is affected or the whole retina is affected, you have to do flash ERG. So there is an logarithm, and it's very easy. So if you have macular pathology, pattern ERG will be abnormal. If you have optic nerve abnormality, you will have a normal pattern ERG and an abnormal N95 in the pattern ERG, and which is the ganglion cell part, and you will have an abnormal VP. So you can do different tests, all the three, and then you can say, okay, this is where it is, and this is, if everything comes normal, then okay, this patient is malignant, or there is a non-augmented cause. So like that you can use this algorithm to test for patients of unexplained vision loss. So just to show, so if you have something like this where you have a good rod response or a subnormal rod response, but the photopic responses are very poor, and these are again blink artifacts which I am showing here. They are not reproducible, they are coming too late, then you will think this is a cone rod dystrophy, and then you will correlate clinically. So when you give the report, you should not say this is cone rod dystrophy. You should say that the photopic responses are much slower than the scotopic responses, and they are subnormal or they are abnormal. And then based on the clinical pictures, they will make a diagnosis. Okay, this patient has photophobia, he has progressive vision loss, he started at 8-9 years of age. Then you say, okay, this is a cone rod dystrophy. But the ERG person should not give the diagnosis, they should only give the findings. So here we have a patient with unexplained vision loss, 6-9 vision. So if we do only VP for this patient because the disc looks pale, it will come abnormal, and then we'll think he has optic neuritis, or he may have color vision problem, he may have photoma. Then we will just go off the track. But it is important in this type of patients to do ERG, and ERG showing that the flicker is abnormal. So this patient has a generalized cone dysfunction. You can also have just a macular dystrophy where only the macular cones are affected, so only the pattern ERG is affected, whereas rest of the ERG is normal, because the number of cones in the macula are a very small portion of all the cones. So all the cones are normal, only the macular cones are abnormal. So your flash ERG will be normal, only macular ERG will be abnormal. So in rod monochromatism, what we find is that there is absent photopic ERGs. There is normal or subnormal rod response, but the photopic are absent. Now we should not label these patients as cone dystrophy. They have rod monochromatism. They are very typical. They come with history of nystagmus, poor vision at birth, which improved little bit with time. They have very severe photophobia. When they walk into your clinic, they'll keep on squeezing their eyes. So you can just diagnose them even without ERG. They walk into your clinic and you can diagnose, okay, this is or odd monochromatic. And when you do the test, this is what you will find. There is absent cone responses, and they are normal or subnormal, and they usually remain stable. Then you can have, what we call as a negative ERG, and there are various causes for negative ERG. So again, when you see that there is no B wave but a very good A wave, you should not say this is CSNB or this is CRAO. You have to give a report that there is absent B wave, there is good photoreceptor function, good A wave. That means it's the inner retina which is affected, the outer retina is healthy. And then based on the clinical findings, you make the diagnosis, whether it's because of CRAO or kidney toxicity as I showed, or congenital stationary night blindness and things like that. But you can have retinoschisis is a common cause. So you can have different types of negative ERG. I use ERG a lot for vascular pathology more than I use it for retinal degeneration, because a lot of retinal degeneration you can actually diagnose clinically by the time they come to a tertiary center. But for example, this patient was sent to me before cataract surgery to rule out diabetic maculopathy. So okay, at a cursory glance one can say okay, there is some diabetic maculopathy, which is 20/50, but there are two signs in this eye which made me think that this is not diabetic maculopathy. One is that you can see there is almost a bald retina. There is no NPDR, hardly any NPDR. You would expect in a CSME patient to have at least some microinzum, some hemorrhage, some NPDR. On background of that, the CSME occurs. So there was nothing, that was all completely empty. And the other was this vein. This vein was really dilated, tortuous, single vein, focal lesion. So then you start thinking that what is happening. So we did an ERG and it showed that there were absent oscillatory potentials and the flicker ERG was very bad. So we predicted that this patient has an underlying ocular-ischemic syndrome, which is causing these changes on the background of some diabetic retinopathy, but she has massive ischemia in the retina. And we want that, cataract surgery, after cataract surgery, this patient can go into neovascular glaucoma. They are at high risk. So we wanted to follow up this patient very closely after cataract surgery. However, they didn't send it back to us. They did the cataract surgery. Patient got 20/20. After 3 weeks, lands into emergency with hypopyon, fibrin, taken up as endophthalmitis, bitter biopsy done, comes negative. After 1 week, they find pressure is 40. She has neovascular glaucoma. We go ahead and do Avastin, ARC. Final vision is 20/80. While we are doing this, we are already aware that her ERG in the left eye is also showing ischemia. And while we were doing this, she developed presbyopia in the other eye. And that eye we did laser, and after cataract surgery, she got 20/20, and she hasn't had neovascular glaucoma. So it is very important when these patients come to you. It's very subtle. Ocular-ischemic syndrome is a very underdiagnosed entity, but if you are careful, you can pick them up clinically, and then you can know about them. Recently, only last week, I had one lady. She came with she's a vice chancellor of a university, and she's been following a retina person all along, and everything was all right. And then she comes referred as PDR. So when I saw her, one eye was totally normal, and other eye has a massive traction and big vessels right in the periphery. So I said, like, this doesn't look like old CRV or BRV. So we did her, carotid Doppler. She has 60% block on that side, right from common carotid up to internal carotid. So you can pick up these patients if you are aware. And of course, we did ERG, and she has severe ischemia both in the right eye and the left eye. So then you can have something like this. So this patient comes to you with this pallor, and you think this is optic neuritis resolved or NAIN resolved because there's an RAPD. Visual acuity is very good, but patient is not happy with the vision. He says he had transient vision loss and then it returned partially. You do a field test, it doesn't show you typical AIUN field. And if you had seen this patient at the time of the attack, this is what you would have seen, that they have little cloudy swelling, and this can be missed. It is transient, it just goes away. So if your CRO has lasted more than 4 hours, you will get the typical cherry red spot. But if it lasts for few minutes and then it recovers, the embolus goes away, you will be left with this type of picture. And this you can only diagnose in the follow-up by your ERG, where ERG will show abnormality, whereas your flicker will show abnormality, your pattern ERG will show abnormality. So you know that retina is affected and not just the optic nerve. So this is the last case which I wanted to say. Patient of retinitis pigmentosa, sent as vision loss due to RP. There is a disc pallor, RP changes, yes. But when we did the multifocal ERG, it showed that this macula is totally normal, where the other eye with the same macula has 20/20 vision. So this is loss of vision not because of RP but because of optic neuritis. So ERG will help you to differentiate. So always do your ERG, but before you order the test, think of a diagnosis, differential diagnosis, what you are going to try to find out, and then when you get the report, you have to coordinate it back to the clinical finding. The ERG alone should not be taken. So I want to conclude by saying that variations in ERG can occur due to physiological, technical and pathological factors. And if you are doing research protocols, then you will need very strict adherence to certain factors. And each lab should have its own normative data. But when there is a pathology, it changes a huge lot. It doesn't change little bit. So it's not like little bit there. So every place should have its own data. This is my hot spice word. So just to say that the languages are different for different people. Thank you.